Welcome everyone to this MOLA event. My name is Jennifer, I am the intern. And we have some of the co-chairs of the advocacy committee along with a member who will be introducing our panelists. Can you please introduce yourselves?
Hi, my name's Janina Guevara. I'm one of the co-chairs for the advocacy committee for MOLA. Thank you so much for being here. So the panel discussion is going to discuss about Immigration Health 101. It's directed towards healthcare providers, healthcare students, just to give us a little bit of understanding about some of the different resources, policies, and rights that are available to uninsured and immigrant communities. And so, we're delighted to present these three expert speakers. We thank them so much for giving us their time and their energy. So the first speaker that I'm going to present is Luvia Quinones. She serves as the Health Policy Director at Illinois Coalition for Immigrant Refugee Rights. That's ICER. In this role, Luvia oversees the Immigrant Health Care Access Initiative in collaboration with ICER's members, develops ICER's health policy agenda with a special focus on access to healthcare and healthcare reform. Preceding ICER, Luvia worked at the City Colleges of Chicago under the Community Relations Department. There, she played an integral role in creating and launching the new department. Prior to working at CCC, she oversaw the first state-funded citizenship program at ICER, the New Americans Initiative. Luvia has a master's in public policy from the University of Chicago and a BA in the International Studies from DePaul University. She is a daughter of Mexican immigrants from Durango, Mexico, and is an active community member in her parish, St. Sylvester's. Currently, she serves as a board member of the Illinois Association of Free and Charitable Clinics and the University of Chicago's Harris School Alumni Council. Thank you so much, Luvia, for being here with us. The next speaker that I want to introduce is Andrea Kovac. Andrea is an attorney on the Shriver Center Health Justice Team, and she works with communities towards providing affordable, comprehensive health coverage and health care to everyone, centering those who have been systematically excluded. Andrea is honored to work closely with Luvia from ICER and Carrie Chapman from legal counsel at many of the tables she joins. Thank you so much, Andrea, for being on this. Lastly, but not least, we have Carrie Chapman. She is the Senior Director of Litigation and Advocacy. Carrie oversees litigation, legislation, and administrative advocacy at Legal Counsel for Health Justice. Carrie has extensive experience serving low-income people through litigation. She has litigated complex cases on the Medicaid program, education access for children with disabilities, immigrant access to benefits, and hospital charity care. Currently, she also teaches poverty law at DePaul University School of Law as an adjunct faculty member. Thank you, Carrie, for joining. So what we will be doing is we prepared a panel or set of questions that we feel it's important to touch on given the expertise here. If anyone has a burning question, please feel free to share it in the chat. Jennifer, one of the interns here at MOLA, will be taking in account all the questions that are coming in. We have reserved about 15 minutes for any questions that are coming from the audience that hasn't been asked during these questions. Right. So I'm going to begin the conversation and with Luvia. Give us kind of a just brief explanation of what it means to be undocumented for people that don't know.
first of all, thank you for the invitation and thank you for having me. I will start answering the question by first saying that my experience as well as my knowledge is more by the lived experience. I myself am not undocumented. I was born here, so I just wanted to say that. But I do have relatives, and up until recently, actually, my husband was also undocumented. So familiar with the process as well as, unfortunately, the experiences and the barriers people have. When we say that a person is undocumented, it's a person that is in the US and has no legal immigration status. That person may have come to the US with some kind of visa, overstayed their visa, or it could be a person that crossed one of the US borders illegally and then stayed here. For purposes of navigating healthcare or accessing healthcare, when a person is undocumented, it is very challenging for many reasons. Many times people that are undocumented also have limited English proficiency, so it's very difficult for them to navigate healthcare, let alone just the bureaucracies that come with accessing healthcare. The other barrier is that based on a person's immigration status, there are very limited options when it comes to healthcare. For undocumented, the most places, you could say the places where people are able to get care are either free and charitable clinics or federal qualified health centers such as Alivio, Erie Family Health Centers, just to name two, and of course the emergency room. When it comes to specialty care and anything, it's pretty much limited. I will also add that there are a significant number of individuals that are undocumented that do have health insurance, mainly through their employer. Given that undocumented individuals are not eligible to apply or not able to get insurance through the Affordable Care Act, the same thing with individuals that have DACA.
Thank you so much, Luvia, for that brief explanation. So you did speak a little bit about some of the barriers, and you did speak about the language barrier, which is a big language barrier. This question's open up to anyone on the panel. What are some of the other kind of additional barriers that undocumented or uninsured individuals face?
I could share some, but others feel free to chime in. I'm gonna focus on one because we're still going through it, mainly because of the previous public charge rule that I think most of us heard about, and hopefully you all submitted comments. If not, get ready to do some stuff around that in the future. But also connected to the previous public charge rule, that is the new, you could say, existing law from 1996. There continues to be a lot of fear and anxiety in the immigrant community, as well as misinformation on what exactly counts towards public charge and what doesn't. And also many US citizen children that have been disenrolled from various benefits, including Medicaid health insurance, because of the parents' fear that it could affect the parents' immigration status. So one other barrier would be, I would say, fear and anxiety. And the other thing I would say, overall distrust in government institutions that unfortunately is somewhat of a consequence of the last few years of immigration enforcement.
And I would add to what Luvia said, that even though you may not have heard the term public charge in your health care office, it shows the fear of public charge has shown up in other ways. So if you do have a patient who has said, well, I don't know if I want to enroll in Medicaid, even though I'm eligible, because it might affect my chances later to get a green card, or just showing reluctance to enroll in programs that you know that they're eligible for, showing increased anxiety or stress, or even showing up to your healthcare provider with maybe advanced disease, or you might be thinking to yourself, I wonder why they didn't come sooner, and they were avoiding the provider's office. So those are other ways that fear of public charge we've been told by healthcare providers that it's been showing up. And then in terms of benefits, it translates to that fear of public charge and having the public charge rule attached to you shows up just by not enrolling yourself in Medicaid coverage or other public programs, or not enrolling your family members. And so, and to back it up even further, for those of you who are wondering what is public charge, so public charge is actually, it's a concept that has been rooted in federal immigration law since the 1800s. And from 1999 up until when the Trump administration came in, the public charge test for immigration officials to be allowed to determine whether someone applying for their green card or applying for a visa to enter the country was determined to be a public charge. That public charge test was very narrow, and it only was allowed to look at basically two public benefits. So the public charge test, essentially from 1999 up until when the Trump administration came in, that public charge test, the narrow one, was determining whether or not a green card applicant or a visa applicant was primarily dependent on the government for subsistence and therefore a public charge. And immigration officials could only look at whether or not that green card applicant was on cash assistance for income maintenance. So that's like ongoing cash assistance from the government that you would get every month for an indefinite period of time, or whether a person, a green card applicant, was in a nursing home, in a long-term care facility, and it was being paid for by the government, so being paid for by Medicaid. And those are the only two benefits that immigration officials could look at for this public charge test. And so when the Trump administration came along, they took this narrow test that pretty much everybody passed, because green card applicants were not even eligible for those two benefits that I just described. And the Trump administration dramatically expanded this test and gave great weight to a lot of other factors. It added looking at federal Medicaid. It added looking at SNAP and housing programs, et cetera. And so when immigrants of every status, not just green card applicants, but immigrants of every status, started to hear rumblings about the Trump administration's dramatic expansion of the test, and then when they actually expanded it, when they issued their final rule in August of, when was that, 2019, then immigrants of every status thought that public charge applied to them, and they were foregoing enrolling in benefits, including Medicaid, or they were foregoing enrolling family members in those benefits. And so, you know, through those years of the Trump administration, that chilling effect of this public charge rule has just been so pervasive, and immigrants of every status have been just confused about what's in the rule, whether it applies to them, fearful, like Luvia described, that even now, that thanks to the lawsuit that ICER is the organizational plaintiff in, the Biden administration took steps to go back to the 1999 rule, the narrow rule. So even though now we've gone back to the more narrow rule, immigrants still are really fearful of public charge and are still not enrolling in the benefits that they're eligible for. So I will pause there and let others speak about that.
Well, so that's really important to kind of understand, especially because like you said, there's a shift, right, from the Trump administration, then back to, but that there's this kind of confusion. You did mention a couple other policies, kind of like SNAP, or does that include, I guess the questions are, what are, for people that don't know, what are the policies that exist out there, or resources that exist out there for uninsured, undocumented individuals? And then do those affect, I mean, does that does that affect public charge in any way?
So I can speak to this a little bit. So definitely coverage options are very limited for people who are undocumented, people without status. And so there are very few government programs, including ACA subsidized coverage, which Olivia explained, that are available to folks. For primary care, Olivia mentioned free and charitable clinics and federally qualified health centers, FQHCs. And then there's also a federal law that requires hospital emergency rooms to screen people who present for an emergent condition. And after that screening, if the person isn't stable, then the receiving ED needs to provide treatment. If the person is stable, they can transfer them to the public hospital system. And so there is some obligation on the part of nonprofit tax exempt hospitals to provide emergency care for folks regardless of their status. Our public hospital system in Cook County, the Cook County Health, treats all comers. They don't require immigration status in order to be treated. And then there is a program that reimburses hospitals for the care that they provide as they are required to under what's called EMTALA, the Emergency Medical Treatment and Active Labor Act. And that's emergency Medicaid. Colloquially, we call it emergency Medicaid. It isn't really coverage for the individual. It's really just a payment source for the hospital that is trying to meet its EMTALA obligations. But we can get federal match for reimbursing claims from hospitals who treat people without status who are not otherwise eligible for Medicaid. It may be, or often it's sort of a question. So that doesn't cover everything. But I think this audience understands, right, that there's a huge gulf between primary care and emergent care, and really they mean emergent care, right? So you could have stage 4 breast cancer, but if you presented an ED, you don't meet the requirements of an EMTALA for treatment. You don't have an emergency, right? You're dying of breast cancer, but you don't actually have an emergency. So the emergency room doesn't have to treat you. So care for chronic illness that is beyond what primary care physicians can provide, access to specialty care, which is not really available at FQHCs and free and charitable clinics, access to screening, testing, imaging, durable medical equipment, all of those things are really outside of any of the categories of coverage that we have for folks without status. And those things are really difficult for people to get access to.
So I put in the chat a fact sheet on emergency Medicaid that Luvia and Carrie and myself and probably a couple others all worked on for more information about that. As far as health coverage, so Carrie was mentioning that there aren't a lot of affordable, comprehensive health coverage options for people who are undocumented. However, Illinois was the first state in the country back in, I think it was 2005, to provide Medicaid, a Medicaid pathway for children who are undocumented. And so eligibility for that, it's called the All Kids program. I'm sure you all have heard of it. Eligibility for that is you need to be an Illinois resident. You need to have household income of less than 318% of the poverty level. You need to be a child under the age of 19. And it's available regardless of immigration status. And it's administered through our Medicaid agency. And then there is another exception for Medicaid, which is for individuals who are pregnant. So Illinois residents who are pregnant, who are under 210% of the poverty level, they would qualify for the Moms and Babies program. And that's through, and again, administered through the Medicaid program. And that is comprehensive health insurance. So, if a pregnant person breaks their leg while they're pregnant, that's still covered. It's comprehensive insurance. And that is also available regardless of immigration status. And then there's also a new program that started in December of 2020 called the Health Benefits for Immigrant Seniors Program. And we have a fact sheet on that, which I'll put in the chat. And this is just like it sounds. It's for Illinois residents who are age 65 and over, who are 100% of poverty or less, and who are undocumented or who are green card holders who've had that status less than 5 years. They can also receive comprehensive Medicaid-like coverage through our Medicaid agency. It covers everything except for nursing home care and a few other benefits, but otherwise it's pretty comprehensive. And then this past General Assembly session, the General Assembly did authorize coverage for undocumented adults who are age 55 to 64 years old. And that coverage will start next spring, so spring of 2022. And I can talk more about that later, but I'll let others have a chance to talk.
Okay, that was a lot to talk about, but really important kind of policies that we've all, that some of us have heard of, and if you're not, this is the first time. Thank you again so much for providing that fact sheet. Having something physical sometimes is really great. And so I know that you talked a little bit about, so going back to public charge, we talked a little bit about the change from the Trump to Biden administration. And I think I'll direct this question towards you, Olivia. Have you noticed has there been any change in the administration and how that's affected healthcare, specifically for undocumented or uninsured individuals?
Yes, so I'm going to answer the question a little twofold, given that on the one hand, things have gotten better in the last few months, but we still face many challenges. So I would say that, again, I mean, ever since the public charge rule did get overturned, and we were able to go back to, you could say, the previous original rule from 1996. In the beginning, people were still, I would say, more afraid than they are now, because for the last, how long has it been? 2 years, year and a half, Carrie and others were the ones in court litigating, so they know for sure the timeline. There was a lot of back and forth, and there was days where we would win one day, 2 days later, we would lose again. So because of the back and forth, when we first announced, as well as advocates across the country announced that the rule was no longer in effect, we got many questions from people like, is it for real? Or is it gonna change? And how long is it gonna be around like this? So there was still a lot of hesitation. I would say that people believe us now, that it's no longer in effect, but there is still a lot of fear and confusion. People still do not know what exactly are the programs that count, which are the programs that don't count. So therefore, that leads to further confusion, besides isolation, besides people not wanting to access many things. As an example, in the beginning with COVID vaccines, let alone COVID testing and COVID treatment, one of the questions we would get a lot in the various events we did virtually for the community was that. Is a COVID test free, and does it count? Is it going to affect my status? Same thing with the vaccine, etc. The fear and the anxiety was way worse when the rule was in effect, to the point that, as Andrea alluded to earlier, people were showing up to their emergency room when they were very sick. Versus going to the doctor for something that, even though it was a chronic illness, could have been, you could say, prevented or could have been taken care of. I won't go too much into it, but in the beginning, when the rule took effect, actually before it took effect, I should say, we heard from many health providers, from clinics to hospitals, of patients foregoing, missing appointments, et cetera, which led us to create a health coalition that I could talk about later, called the Illinois Alliance for Welcoming Healthcare. It was a doctor's idea, Dr. Ansel from Rush, and we kind of ran with it. I will also say that, again, even though the rule is no longer in effect, we just see it sometimes in even other things. As Andrea alluded to earlier, one of the programs that was originally part of the Trump public charge rule was SNAP. So when a PBT, which was food assistance for children that were receiving free or reduced lunch, got implemented, many immigrant parents did not want to use those benefits, even though the children were eligible, even though they needed that assistance. Just as an example of, again, how much that immigration enforcement and immigration policy really affects people day to day.
Thank you so much, Luvia. And Andrea, I don't know, or Carrie, I don't know if you have anything else to add. Okay. So to the next question, and kind of like a little bit of also like why we're here. You know, a lot of us are healthcare providers. A lot of us are healthcare students. We work in clinics. So sometimes I get the question, you know, why is it important for healthcare providers to know about these kinds of policies and things like that? I know that everyone has worked with healthcare providers, so this question is open to anyone.
So I think for a couple of reasons. I mean, one is I think that you guys see this directly, but I think it's also helpful for all of us in the, you know, in this space, that we kind of take a step back sometimes and get the 30,000 foot view, that the federal government has been driving the engine of fear quite intentionally, right? And admittedly, they admit that this was their goal. And so we see people acting, in ways that don't seem sort of to advance their medical interest. And that's hard and frustrating. And I see people who, are not interested in enrolling in benefits that I know would be helpful to them. And so I think it's important for us to remember and have that context that the federal government, which has tremendous power over the lives of immigrants, right? If you don't get a green card as a result of having being called a public charge, then either you are not in status and you stay out of status, or you had a status and it expires and you are identified to immigration authorities. So they can come and pick you up and deport you. If you were an LPR applicant, you were using a family-based pathway to adjust. So your family that was helping you adjust here, you will be deported away from them, your husband, your wife, your children, your parents, your siblings, you will be deported away from them. The consequences are enormous. So I think it's important for all of us to have that context as we see people making decisions about their healthcare and benefits, and not to lose sight and to lose touch with that. Also, I think, the immigrant community is very concerned about the cost of healthcare. Everyone's concerned, but the immigration community is very concerned. And we need to remember they're very concerned because coverage options are very limited. And so they are, in fact, likely to be on the hook for the bills for their medical treatment. So they are price sensitive. This is not a surprise, but it's important to keep that in mind, right? That people are going to make price-related decisions about engaging in healthcare, even in COVID care. And we need to understand that, again, that is by design, right? They are responding to a system that the federal government created specifically to get them to respond in that way, right? Disenroll from benefits, don't get healthcare. We want to hurt you. That the cruelty is the point. And so I think not losing that context is important. And then also just understanding that there are some options, but those options may not always have penetrated into immigrant communities. And so making sure that we are the people sharing the information. Hey, there's a new program, health benefits for immigrant seniors. Hey, if you're applying for a U visa or a T visa, you can get state funded Medicaid, and helping people understand what their options are. And you guys in particular are a trusted voice, right? We've seen time and time again from information on vaccine uptake that people are heavily influenced by their care providers saying the vaccine is safe and right for you. And really the same thing is true about things like insurance coverage and options, right? If you can say, hey, there's a program that you're eligible for, and here's a place that can help you enroll, then your voice in communicating that is really important. We can only touch so many people. You can touch lots more, and we can help people get into programs that are safe and good coverage for them. So I think it's incumbent upon all of us to up our game and our perspective and our expertise, so that we are meaningful allies with our communities in recognizing that their fear is justified and well-founded, and in helping them navigate their justifiable fear to access to healthcare that we know is in fact what they would choose if they could choose it without a penalty.
Thank you so much, Carrie, for sharing that. That was a great point, and definitely, something to keep in perspective of all the, healthcare providers that we have here. I know that Andrea, you mentioned a little bit about the kind of the program that's coming or that's available that just passed or is getting signed. I think it's SB 1840. Can you kind of divulge on that a little bit?
I'm going to throw that right to Luvia or Carrie. They're actually experts on that one. Yep.
Yeah, so I think that, before I answer, just to clarify, I think, Janina, you may be talking about, so there's the expansion of Medicaid that will be going into effect, as Andrea mentioned, next May. That's for people that are 55 or older. Anybody that's a non-citizen, including undocumented, as well as legal permanent residents with less than 5 years. And then the other one, which is the SB 1840, for those of you that don't know, any kind of potential legislation gets assigned a bill number. So we're referring to one that I forget which one, if it originated in the Senate versus the House, but point is, that's the bill number. And we're talking about the Hospital Accountability and Transparency Act, which hopefully will get signed sometime in the summer. The focus, or I should say the highlight of the bill, which is one of the reasons why we as well as many of our members supported it, is because it increases hospital financial assistance for people that are uninsured. It does other great things, including transparency around data collection and other things. But for the uninsured community, one of the main things is, again, it increases hospital financial assistance. And the way that it's going to do that once it takes effect, which should be January of 2022, is for a person that is uninsured and is a patient at either a federal qualified health center or free and charitable clinic, if they need some kind of specialty care, some kind of just hospital service or a service that gets provided at a hospital, whatever that may be, as long as they get a referral from their provider, they would be able to get that service for free. Because most of the time, patients of those clinics are uninsured and are low income. Some of these things, you could say this policy was somewhat in existence before. The enforcement, let alone the actual implementation, was really bad, to say the least. And many times people only received hospital financial assistance when they got service through the emergency room. So now people again would be able to receive it, apply for the hospital financial assistance before they get the service, which is a huge win for the community, because many people end up foregoing care out of fear that they're going to end up with a high hospital bill.
Thank you so much for explaining that. And the difference is, I got confused a little bit. And so the other thing that I also wanted to talk a little bit more about and get an explanation what we as healthcare providers can do to become more immigrant friendly. I know that you all spoke about Welcoming Alliance and that it was started by a physician. If you could maybe expand on it a little bit more and on kind of other areas that we as providers can become more immigrant friendly.
Sure, I'm happy to start, but Andrea and Carrie, you guys have both been involved, and Andrea actually is one of the main authors of the model policies, so I won't get too much into that. So as I mentioned before, Dr. Ansel from Rush is the one with the idea, and then we just ran with it, mainly again because back in 2018, I think it was. I'm trying to remember. We were doing public charge for the longest. I'm blanking out on the years, but sometime in 2017, 2018, we started hearing from many providers, as I mentioned earlier, about what they were hearing from patients about not wanting to go to the hospital or literally just missing appointments, including mental health providers. So the idea behind the Illinois Alliance for Welcoming Healthcare originally was to create model policies that would kind of be used as a sample, as a roadmap for health providers, including clinics and hospitals that would want to learn more about what can they do to not only create a welcoming environment within their health institution, but also other simple things. If they want to tell people that immigration is not welcome at their facility, what kind of signs can they put up? What kind of the various languages that for our community is important? If they are keeping certain information in the person's medical records, what should they and what should they omit? So it goes into a lot of details. Again, I won't go too much into it because Andrea could speak more to that, but it's a great resource. We meet right now because of COVID, we have been meeting monthly. People are welcome to join. We do ask for people to commit to the mission and the vision of the Alliance, which you can find on our website, which I'll put in a second in the chat. But we have providers, anything from hospitals to clinics involved, as well as a few medical, as well as law school students involved.
Thank you so much, Luvia. Andrea, she kind of talked a little bit about what you should put in medical records. That's kind of interest to us a little bit as healthcare providers. Can you give me just a little summary about what your recommendations are?
Oh goodness, I need to go back and look at what I
have a couple,
Yeah,
Andrea. Do you want to look? And I'll say the couple I know.
Oh, perfect, Carrie. Thanks.
So one thing that can be helpful is not to put all over someone's medical record their status, their immigration status. You're very unlikely to be required to disclose that record. There's a lot of protections, but it's certainly not completely sacrosanct. And so if you don't need it, don't put it in there. The other thing is when you have EMR subsets that have an SSN, a social security number option, there's sort of two challenges with that. One is that it means you're probably asking people for their SSN, or not maybe you, but people in the office are asking people for their SSN. And just as price and fear of cost is a trigger for folks without access to insurance coverage to not engage in healthcare, being asked for an SSN really does cause people to think this isn't a safe place. Maybe I can't get care here. Maybe this is going to be a problem. And so if you don't need the SSN, don't create fields for it. Don't ask people for it. Only ask when it's absolutely necessary, but don't make it standard operating procedure to request an SSN. It is really off-putting to people. And you may not see it or understand that it's happening, but you may have people kind of disengaging from care because they just feel like this isn't a safe place. And I don't know that I can go there without an SSN, and you don't want people giving an SSN that they might be working under to you. And then you're trying to apply for Medicaid under this SSN. Like, if you don't need it, don't ask for it. And then the other thing is that if those records were ever disclosable, right, and you have an SSN field and it's filled out in 10 cases and not filled out in 3, well, you've essentially said, here, these 3 people don't have status. Those 10 people do, these 3 people don't. And so again, you're just sort of creating a record that increases people's vulnerability. And again, obviously, your medical record is protected by HIPAA. It's highly protected. But something you all should understand is that nobody beats ICE. There are strong federal laws that say if ICE wants information, other federal agencies, state government, everybody has to give it. It basically, their right to information trumps everything else. Now, obviously, you would fight that. The state of Illinois would fight having to disclose information to ICE. It's not that we would all just roll over, but the law is on ICE's side. So don't create a medical record that either is off-putting to your patients and makes them feel fear, or that, if revealed, gives information about your patients that isn't critical to their care, right? If their undocumented status isn't clinically relevant, it doesn't need to be in your record. That's what I remember, Andrea.
Yes, and your memory is spot on. I'm actually going to just put in the chat where it is in the model policy, but everything that you just said is actually included in the model policy. So I won't say it again. But and then I just wanted again to emphasize the point that Carrie and Luvia made earlier about don't underestimate the value of just being a meaningful ally and empower yourself with information that you can then pass on to your patients who are immigrants so that they then have accurate information. And sometimes that accurate information, and a lot of times happens to me too, is directing them to ICER. Because ICER has so many resources, and ICER has the Immigrant Family Resource Program. And if you only have 15 minutes to talk to your patient who's an immigrant, but you can tell that they're feeling a lot of anxiety and fear, and you know that they would like to sit down with someone and speak to them in their native language for an hour, I'm going to throw it to Luvia. That's the Immigrant Family Resource Program.
Thank you, Andrea. Yes, I'll go ahead and put the info for the program and what the program does. I'm in the chat in a second. But the Immigrant Family Resource Program is a partnership with the Illinois Department of Human Services, and we work with about 35 organizations statewide. So pretty much wherever there's an immigrant or refugee, more than likely there's an organization that is either a member of ICER or a partner through this program. And the program, coincidentally, was actually created a little bit over 22, 23 years ago as a direct result of the 1996 welfare law. So again, the last time something happened around public charge, because we knew that there was going to be confusion, misinformation, et cetera. One of the highlights, or you could say one of the cool things I think of the program is within our program partners, our partners have the language capacity of about 55 languages. So pretty diverse geographically as well as languages. And what the program does is it helps people that are limited English proficient navigate health and human services. So they will help people apply for anything from Medicaid to SNAP to SSI, as well as hospital financial assistance, the new Immigrant Health Seniors Program that Andrea was talking about earlier, pretty much any program for the most part that's under the Illinois Department of Human Services, they will help them. And they also do outreach education. And because sometimes these systems are a little difficult, they will also advocate and make sure that people are getting the right information, let alone enrolled. But again, I'll put in the chat the website where you could type in, either look up the list of where your patient may be. Sometimes the list of organizations may change. We are in a state fiscal year, so sometimes change a little bit, but for the most part on our website, you will always find the most updated list.
Thank you so much. all three of you. Really great information and something to keep in mind when we're in clinic and dealing with our different situations, especially with applying to all these really difficult policies and programs. So I know that we are just at about 15 minutes towards the end of our conversation and panel discussion. So what I wanted to do now is just kind of open up the room or space for other people to ask questions. Jennifer, has there been any questions that have come in from the audience, or anyone feels like they have a specific question for our panelists?
I know
Hello.
there was a, oh, sorry.
Hey,
okay, you can go ahead.
Hey, my name is Walberto Munoz. I am a third-year medical student at the Medical University of South Carolina, and that's in Charleston, South Carolina. So I'm in the Deep South. So unfortunately, that has a lot of implications for immigrants, and especially undocumented immigrants. Lots of angst around having to speak and protect different populations of undocumented immigrants. My big question is, how can I help when I see language access issues? Specifically, I believe Title VI makes it to where all federally funded health clinics have to have an interpreter, but I just don't see that being followed. So like, what do I do in those instances?
I'll give you the advocate answer, and then others could give you the legal answer, as well as lawsuits and all that other stuff that could happen. So yes, unfortunately, things are a little bit harder in the South, as you just said, Gualberto. Sorry, I was trying to make sure I didn't mispronounce it. I would say one of the things is, first, more than likely, somewhere nearby, there will be an immigrant advocacy organization. Like ICER, we do have sister coalitions throughout the country. Some of them do work on health access rights, as well as just doing advocacy. So one would be to find out if there's something close nearby where an organization may be looking at this, or even sometimes legal aid clinics that do this. But again, I'll turn it over to Andrea and or Carrie that could explain a little bit more on potential things that could be done.
I mean, there can be a lawsuit. So I think Ruby is right that connecting with immigrant advocacy organizations and legal aid organizations, and there are legal aid organizations in South Carolina, can be helpful, because it may be that you're at a situation where just like the institution isn't going to change its practices without a lawsuit. But I would say that lawsuits are expensive, time consuming, difficult, and sometimes you lose. And so they're definitely the route of last resort in almost every situation. And so I think a couple of things that can be really effective with healthcare institutions is there is some evidence out there about how your liability increases when you are not communicating with people in an effective way, right? Do you have informed consent? Are patients able to follow their discharge instructions? Are they able to be treatment adherent? If they are not understanding, then all of those things are much less likely to go well. And so there's evidence about hospital readmissions, right? And Medicare doesn't necessarily reimburse your hospital for readmissions within a certain period of time. So one option is to sort of appeal not to the better angels of their nature, but to their bottom line, right? How would the interest in having appropriate interpreters align with the fiscal interest of the institution and the risk compliance interests of the institution? And so sometimes you have to be a little Machiavellian and try to think about where those interests overlap, and not just think about sort of carrying the sword into federal court. And I think that can be helpful too. I also think there's good evidence on the trauma that's inflicted on young family members having to translate medical issues for their parents. And I think, again, this is a little bit more of a mission point, but just to say, like, are we an institution that inflicts trauma on children, or are we not? But language access is a huge cultural commitment, and frankly, it's a financial commitment. It just is. And so I think it is, if hospitals are going to move dollars, then you're going to need kind of a multifaceted campaign. The other thing is really that what we have seen, and I think this is really true everywhere, is it's, sort of humans on the ground that move institutional change. So partnering with those immigrant advocacy organizations, it's a lot harder for a hospital to look 100 community members in the eye and say, I don't care if you don't understand your discharge instructions, and die. It's a hard thing for them to do. They don't like it. They don't want to do it. And so don't underestimate the power of just flat out community organizing.
We've had to do that for other issues. So just to say that, and I added a few other, another suggestion in the chat as well.
Thank you so much, Carrie, for and both Luvia for talking about that. Jennifer, is there any more questions that you saw in the chat that, or anyone that has a question that's
I do see that Mayra Flores, she wrote, what is an effective way of spreading this information to those who may not be aware of these options or programs?
So us, in the sense of, I would encourage organizations, if they're not a part of the Alliance for Welcoming Healthcare, right? We're constantly talking about these things in meetings, and lots of good information is, fantastic. The three of us and our organizations do presentations all the time. We're happy to come and talk to healthcare providers about new programs. I know Andrea has done trainings on the health benefits for immigrant seniors. Luvia has done trainings on everything under the sun related to immigrant benefits. Somebody wants something specific on emergency Medicaid, we're a good resource for that. So I would say there's good websites, the Alliance website, ICER's website, the Protecting Immigrant Families website, lots of materials there. And then if you have a particular audience that wants a particular issue explained to them, or program explained to them, then reach out to us. And even if I'm not the right person, for example, and you reach out to me, I can get you to the right person. Sorry, Luvia, you were going to say something.
I was just going to say that I think the answer in regards to the most effective way depends on the setting and the audience. So for example, depending, the question is from Maida. So Maida, hypothetically, if you're asking what's the best way for either US medical students as future doctors, nurses, et cetera, not knowing who's here, then the little that I know about how things happen within health institutions, then thinking about what is the place where most patients get their information. Is it through the social worker? Is it through which department? And making sure that those departments have the information needed. And again, I cannot encourage enough that as much as possible, reaching out to organizations like any of ours. We're always happy to not only give presentations and trainings, but also share resources. That's why we create these fact sheets that sometimes are a little cumbersome, but we want to make sure that people do have access to them. So again, depending on what the setting is, it could be a couple of different things. We have been reaching community members during COVID through Facebook Lives, as well as through pretty much any place that is possible, and then making sure that immigrant serving organizations have the correct information, because a lot of the times that's where immigrants get the information from trustworthy source.
If I could just add, and I'm not sure how many people are on this webinar that are living and practicing in Illinois. I know Gualberto just said he's from South Carolina, but for those who are based in Illinois, there is a resource called Help Hub for Illinois-based social workers, caseworkers, financial counselors, anyone who works with immigrant clients or immigrant patients to get questions, to ask questions and get questions answered about immigrant eligibility for public benefits or about public charge. It's an online technical assistance portal, and I can put the link in the chat. It's just called Help Hub. And right now there's over 2,300 of those folks, the social workers, caseworkers, financial counselors in Illinois that are registered users of it. It is free. Carrie Chapman, Luvia, myself, and others are the ones answering the questions. And so some of, a question might be, is someone who's undocumented eligible for SNAP, or where can they go for nutrition benefits? Or I have a client or a patient who is concerned about this. What resources would you suggest? And all the questions are answered within 24 hours. It's also a place to share resources, learn about webinars and upcoming events. So I would highly recommend that if it doesn't sound like it's you, maybe it's someone in your office, like the social worker, like Luvia mentioned, that they register for Help Hub, so that they can just have an online expert. It's free, that can answer their questions too and link them directly to resources. So I'll put the link for it in the chat.
Thank you so much, Andrea. Great resources. Again, like something that I didn't know about. Any other questions that are from the audience or in the chat?
I think the ones that were asked were answered. I think, oh, Erica, I think she posted something. Would you mind summarizing the main policies or changes in policies either brought up today or not yet mentioned that you feel are important for healthcare providers to know, and which are specific to Illinois versus federal policies? And if you also have, like, to all our speakers, if you want, I can also take all the resources you posted on here and like send them over to our attendees as well.
So I could just quickly say emergency Medicaid, which again is basically not coverage for folks, but it is reimbursement for hospitals for meeting their EMTALA obligations through the ED, is a federal policy. All states participate in the emergency Medicaid program. And so there's an EMTALA obligation in all states, and all states can get emergency Medicaid reimbursement from the feds. The public charge policy that we talked about is federal immigration law. And so it's in a better state than it was, but that's not something that's state specific. It was a federal rule designed to create barriers for people to get their green cards. And it is now a federal rule back to a very limited set of benefits usage that might jeopardize your green card. Essentially, almost no one will be caught by the public charge rule anywhere in the US. Your obligations for translating come under and interpreting come under federal law. And the other programs that we talked about, so the health benefits for immigrant seniors, the coming health benefits for those 55 and up who aren't otherwise eligible for insurance because of status, are Illinois specific programs. Many states cover kids who are undocumented. Illinois is not unusual anymore in that, but we were specifically talking about all kids in Illinois. And then charity care is very different place to place. So Luvia gave a great explanation of expansion in charity care. I just will say that all hospitals have a federal tax exemption. And that obligates them to provide some charity. Basically all nonprofit tax exempt hospitals in any state have a state property tax exemption, which is a very valuable exemption to them, very valuable. Those property taxes in any urban area would be very high if they had to pay them. States vary tremendously on what charity care is required of those nonprofits. So when we were talking both about the new law and general charity care obligations, we were talking about Illinois, but you can connect with legal services agencies in your state and find out what nonprofit hospitals are required to do in your state. And a couple of states, Maryland and a couple of others, have just passed better charity care laws just this session right now, that's happening right now in a couple of other states. So definitely look it up in your state, but that's state by state, because the federal tax exemption doesn't really offer people that much, but that property tax exemption, which is governed by state law, can be really robust depending upon where you are. If that's sort of a helpful like rundown of federal versus state.
Thank you. Thank you so much, Carrie. That was a great kind of summary. And I know it's 6:30, so I want to, thank the panelists, Luvia and Andrea, and then Carrie. Thank you so much for sharing your time with us. We think that it's very, very important to have these kind of conversations, especially with healthcare providers. So we appreciate you giving us this time.